All right, so next is an introduction to procedure coding and billing. So we've already done evaluation management. Now, how do we bill procedures? So the objectives of this talk are to understand the basics for coding for procedures, surgeries, installations, irrigations, things like that, and what are the rules that are involved in coding for procedural services. Procedural services need certain documentation requirements, so it's important to understand the documentation requirements. Understand what a global period is and what is included in a global period and what's not included in a global period. That's really important to understand what is billable and not billable when performing a procedure on a patient. Then finally, to understand the main CPT modifiers and their appropriate use. There's a number of CPT modifiers, and they have specific uses. And again, these modifiers are meant to allow for payment or to describe payment, whether a little bit more, a little bit less, or none at all, or some at all, in unique situations. And it's important to be able to disclose exactly what you're doing so you can seek appropriate reimbursement for what's being performed. CPT codes are 5-digit codes. The code set is owned by the American Medical Association, and yearly there are updates, new codes, change of codes. And so we have to make sure that if there are codes that are updated yearly, that we know what they are. Those are if they affect us as urologists. CPT codes include the evaluation management codes, which we discussed separately, but that's its own subset of CPT codes. The ones I'm talking about for this lecture are surgeries, injections and installations, and diagnostic tests such as ultrasounds. So basically everything that's not evaluation and management codes. So it's really important to understand the global concept, the bundling concept, and CPT modifiers. I'm going to get to each one of these things. So global concept is that when a procedure is valued, whether it's a radical prostatectomy, whether it's a cystoscopy, whether it's an intramuscular injection of a chemical or a hormone, there's a global period. That means you're already getting paid for the pre-procedure work on that day that's associated. So if you have a patient for a cystoscopy, all the work getting them ready for the cystoscopy on that day is already prepaid as part of the global for the payment for the cystoscopy. So everything, any related evaluation management is paid. The procedure itself, including all the supplies and all the medications, so you can't bill for supplies separately if it's included in the procedure because the value for those supplies are included in the value of the payment. And post-procedure work. Now, all procedures have a global period, and typically it's a 0, a 10, or a 90-day global, at least for surgical procedures. A 0-day global procedure means everything's already been paid on that day. 10-day global procedure for the next 10 days, everything's been paid. In a 90-day global procedure, which are most of our major surgeries, the next 90 days have been prepaid with the value of the surgery or service that you're performing. Now, obviously, there's exceptions that exist to the pre-procedure work, the intra-procedure work, and the post-procedure work, and I'll get to those, and oftentimes we'll need modifiers to help describe that, why we want to bill something separately. Bundling concept is when billing for procedure, the other associated work is already valued and can't be billed separately. So if performing a cystoscopy with a ureteroscopy, you don't bill for the cystoscopy separately. The cystoscopy / ureteroscopy value is already paid with the procedure itself. So common bundle is a ureteroscopy and a ureteral catheter. Usually you need to place a ureteral catheter to place a guide wire up to do a ureteroscopy. So 52005, cystoscopy with placement of ureteral catheter, is bundled to 52356, which is ureteroscopy with laser lithotripsy and stent placement. So they can't be billed separately because they're bundled together. So for example, I always see people when they're young, they try to bill dilation of the urethral meatus, cystoscopy, ureter catheterization, retrograde pyelogram, dilation of a ureter orifice, they can get the ureteroscope up, lasering the stone in the ureter, lasering the stone in the kidney, and placing a stent. These all have pretty much their own CPT codes if done by themselves, but the access to and cleaning up of procedures is typically bundled. And for example, in this case, what you can bill is 52356, cystourethropy, which includes 52000 cystoscopy, which includes dilation of the meatus if you need to just get into the urethra to get up into the bladder. The ureteroscopy and laser lithotripsy is all included. The 52005 is included. If you're dilating just the ureter orifice just to get up, 52344 is included. Stones in the ureter and kidney on the same side are bundled together. You can't build them separately. And the stent placement is bundled into the 52356. Now you can build the 74420 for interpretation of a retrograde pyelogram if you're performing a retrograde pyelogram and interpreting it there. As you can see, everything else is already bundled. So everything that is access to the patient and cleaning up is already included and valued in the payment itself. Similar, I've heard people who want to do a laparoscopic exploration and lysis of adhesions before performing a laparoscopic partial nephrectomy. Then they want to do a nephropexy, repairing abdominal wound fascia. So these are all sort of all bundled together. When doing a procedure, the goal of any CPT code is that you really need one code that should encompass the entire procedure, and it's valued that way. There are modifiers that can describe unique situations when you want to get paid more, you're asking to get paid a little bit less because it's the right thing to do, or there's unique situations when you should get paid when normally you wouldn't get paid if you didn't have a modifier. So for example, modifier 22, unusual procedural service. In the previous example, we talked about the nephrectomy with an extensive lysis of adhesions. If you're spending an hour lysing adhesions, takes an extra hour than typical, put that in the chart. You can bill modifier 22. You may get paid a little bit extra for your extra time that it took above and beyond your typical time to do a radical nephrectomy. Professional component in the 74420 example, which I described, the professional component is when you're just doing the interpretation of a service such as a diagnostic test. In the case of a 74420, if you're doing it in the hospital and the hospital owns the equipment and you're just doing the interpretation, add modifier 26, describe that you're just doing the interpretation because the technical component, the other half, goes to whoever owns the equipment, which in that case would be the hospital. Reduce services. If you're doing a procedure but you don't do all the steps of the procedure for one reason or another, you just don't need to, like part of it's already been done, you may use a reduce services modifier. It takes away a little bit of the value of the payment. The RVUs stay the same, but it's the appropriate thing to do if you're not performing a full procedure. A discontinued procedure is a little bit different. If you have to stop a procedure once you started because of a patient's health concern, if EKG changed, you have to stop early. You put the 53 modifier to show that the procedure was discontinued early. You didn't complete the procedure because of a patient's health condition. Modifier 58 is important. If you know in advance you're going to do a stage or related procedure, you put this on the second code. And for example, if you're doing a percutaneous nephrolithotomy, which has a 90-day global, but you also plan on doing an ESWAL within that 90-day global, describe it in the original op note. During the percutaneous nephrolithotomy, you say, sometime in the future, I'm also going to do an ESWAL. When you do the ESWAL, you put modifier 58 to describe that you knew in advance this is going to be a stage or related procedure. Otherwise, you may have trouble getting paid for both procedures. Modifier 78 and 79 is if you return to the operating room during a postoperative period. Modifier 78 if it's related, let's say you have to take somebody back for bleeding, and 79 if it's unrelated. So for example, 78, if you have a patient who had a photovaporization of the prostate and has bleeding, has to go back 2 days later, you put modifier 78 on the cystoscopy with fulguration that you're going to perform to show that it was related, to make sure you can get paid for that procedure during the postoperative period and to know that it's related. If it's unrelated, 79, you actually get paid your full value. Let's say a patient has a kidney stone 30 days after having a radical prostatectomy. Typically, you wouldn't get paid for the ureteroscopy unless you put the modifier to say that this is an unrelated procedure. During a postoperative period, I should get paid normally. So modifiers are important. And again, my example about the modifier 22, if you spend more than an hour doing an extra lysis of adhesion, put that in your op note. What's not appropriate, there's people who say, well, I should automatically be able to use modifier 22 because I'm a specialist, and so therefore I get harder cases. Unfortunately, that doesn't meet the definition of modifier 22. So let's talk about some actual real life examples of using CPT codes. So CPT code 50545, which is laparoscopic radical nephrectomy. If you actually read the description, it says laparoscopic radical nephrectomy, including removal of Gerota's fascia and surrounding tissue removal of regional lymph nodes and adrenalectomy. Anything that's in the parentheses like that means if it's performed. It doesn't mean it's need to be performed to bill 50545, but if you happen to do a lymph node dissection and adrenalectomy, you wouldn't bill for those separately, even though those have separate codes because they're bundled together. Again, you'll pull an ICD-10 code, C64.1 or C64.2 if you have known cancer on the right or left side, D49.511 or D49.512 if it's a renal mass that you don't know what it is yet, and you haven't proven it's cancer, again, right or left side. Now, again, this says 25 work RVUs associated with it, and that's a high number of RVUs. But what's included in the payments for this procedure includes seeing the patient the day of the surgery, updating the patient's H&P the day of the surgery, getting their consent, bringing them to the operating room, getting them positioned, intraoperatively performing the procedure, postoperatively, all related postoperative care for the next 90 days has been prepaid. So all your hospital visits, your discharge from the hospital, seeing the patient in the office, any complications handled outside of the operating room have been prepaid already. None of that stuff can be paid separately because of the 90-day global. And it works out. Sometimes you use fewer days, sometimes you need more days. It evens out at the end. Once again, if you do a radical nephrectomy with 1 hour lysis adhesions, I would dictate the extra time above typical into the operative note. And why it was that extra time, add modifier 22 to 50545, probably get paid a little bit extra. We asked about, I mentioned this before, treating stones in both the kidney and ureter on the same side. Although we want to believe that the ureter and the kidney are separate structures, and if you have a stone in the ureter, it's more work to also go up and remove one in the kidney, and sometimes you need different instrumentation. But if you look at the CPT code itself, it specifically states, do not report 52356, which is ureteroscopy with laser lithotripsy and stent, in conjunction with 52332, which is the stent placement, because obviously that's included, or 52353, which is ureteroscopy with laser lithotripsy without a stent, when performed together on the same side. And then there are some people who want to try and unbundle and say, well, I can get paid a little bit more if I do a 52353 ureteroscopy with laser lithotripsy and 52332 ureteroscopy, cystoscopy with stent. I can get paid more if I bill both those, but that's not allowed because the code 52356 exists. And again, the goal is that CPT wants us to bill one code when possible when doing procedures. Again, the practice expense of a lot of things is already included in some procedures. So for example, 51702, which is a placement of a Foley catheter, the practice expense includes the catheter itself. So there are some people who want to bring in a catheter from the outside, bring in their own catheters, but you have to bill 51702, and as part of the payment for the practice expense, we have to supply the catheter. That's just how it works. There's some people who want to use 52, the reduced services modifier, to help reduce the cost to say, well, then that's legitimate if they bring in their own catheter. That's not how it works. Modifier 52 reduces the surgeon fee, but not the practice expense. So really, anytime a patient comes in for a catheter or catheter exchange, we supply the catheter. Sometimes you may share a surgery such as percutaneous nephrolithotomy along with interventional radiology, and there are different codes. And if a urologist performs them all, they can bill multiple codes. If the urologist shares it with an interventional radiologist, we decide who the interventional radiologist, what they bill and what the urologist bills. So for example, interventional radiology gets the percutaneous access, urology dilates and does a percutaneous nephrolithotomy greater than 2 centimeters. How does each service code? The 50081 code, percutaneous nephrostolithotomy or pilostolithotomy, with or without dilation to get access, or of the access, endoscopy, lithotripsy, stenting, basket extraction, anything over 2 centimeters is all included in CPT code 50081. This code includes the dilation of the tract, placing the stent, and nephrostomy tube if it's performed. Interventional radiology, well, they'll get, their access would be 50432, which is nephrostomy tube placement. Here's another example. A month after radical prostatectomy, a patient presents with a kidney stone. The patient ended up needing ureteroscopy. How do you code? Well, there's an established patient. So when they come to see you with the stone, you use modifier 24 on the E&M service. That's an unrelated E&M visit within the global period because ICD-10 N20.1 ureter stone, and a ureter stone has nothing to do with prostate cancer or having a radical prostatectomy. You see them and do all the work, and let's say you bill a 99213 or 99214 evaluation management. One, we have to know that it's legitimate to bill, which it is. And number two, typically modifier 24 would need to be placed onto the 99213 or 99214, whatever E&M code it is, to show that this is unrelated to the radical prostatectomy. Otherwise, it would typically be kicked back and would not be paid. If the patient is then brought to the hospital or brought to the ambulatory surgical center for ureteroscopy with lithotripsy stent, CPT code 52356, and again, we would use ICD-10 code N20.1, excuse me, not 01, but N20.1, and CPT code 52356 for the cystoscopy with ureteroscopy, lithotripsy, stent, and modifier 79 that says we're returning to the operating room for an unrelated procedure within the global period. 3 days after a TURP, a patient has gross hematuria with clots and comes to the office. I spend an hour irrigating. Is this billable? Unfortunately, no. All complications handled outside of an operating room or dedicated procedure room are included in the value of the service. If the patient did need to go to a procedure room or an ambulatory surgical center or hospital for cystoscopy with fulguration, one could then bill, or one should bill at that point, 52214, which is cystoscopy with fulguration, and modifier 78, return to the operating room for a related procedure within the global period. Patient presents for an injection or installation or a diagnostic procedure such as BCG installation, PTNS, urodynamics, LHRH injection. Can I bill for an office visit? The answer is typically no, because the related evaluation management that for these procedures, which all have what's called a 0-day global, BCG installation, PTNS, urodynamics, and such, it's a 0-day global. So all associated evaluation management that has to do with that process is included in the value of the injection or installation. Now, there are certain exceptions when you can bill separate identifiable reasons or treating an underlying disease, which can be done, but those are really the exceptions to the rule and not the rule itself. If somebody presents and they are pre-planned to get 6 consecutive BCG therapies, each week an E&M code should not be billed and probably should be billed for none of them because you're not doing new management. And clearing the patient for the BCG that day is part of the E&M service of the placement of the BCG. You have to clear them for the BCG that day. That's included in the value of the BCG installation itself. LHRH injections, similar. Typically, if the patient's coming in just for an LHRH injection, you should not be billing E&M service. If you end up that you're doing significant and identifiable treating the underlying condition, you have to do new management of the prostate cancer, you're doing certain monitor the prostate cancer, and you document it well, you could bill an E&M service separately, but it needs to be documented well where everyone can understand it. Thank you for your time.